So welcome back guys. Here in this section we will be talking about a longer program, that is the NVB-DCPS, that is the National Vector-Borne Disease Control Program. So many of diseases it is covering in itself, that is the NVB-DCP, that's why I call it as a big program. So here we are talking about the disease which will be covered under this program, that is the very first one is malaria, yes, and the very bigger one as well, malaria. Then we shall be talking about the Filariasis, right, Dengue, Chikungunya, right, then Japanese Encephalitis and kala-azar. Okay, so these are the diseases which are covered under this program, that is the NVB-DCP. That is in itself can be a question, that what kind of diseases, what number of diseases, what shall be the diseases which are covered under the NVB-DCP program, that is the 6 diseases, right, that we have mentioned just now. So in the very first one, let's talk about, I'm just taking the very first one guys, that is the malaria. Okay, so I'm taking the very first one, and that is the malaria. Okay, so in the very first place we shall be talking about the indicators of the malaria. So what are the indicators of malaria? Just some points about the indicators. So the very first one which we shall talk about over here, that is the API. API is the annual parasite incidence rate. It is the annual parasite incidence rate. Annual parasite incidence rate, right? So basically you just need to remember the formula of the API. API says that it is a ratio of number of confirmed cases of malaria, found in any particular region, to the total population, to the total population, right? And multiplier over here would be the 1000. So please do remember that patient, the number of confirmed cases of malaria in any region by total population multiplied by 1000, that is the annual parasite incidence rate, that is the API, right? API also tells us about the incidence and the impact of the malaria on a particular region. So according to the malaria control program, it is telling us about the incidence and the impact of the malaria control program, right? So API also tells us, right, API indicates, or API tells about the incidence and impact of malaria control program, right, that how efficiently it is working in the community. Okay guys, once you talk about, so this is the program, fine. Now let's talk about the next one, that is the ABER, or we shall call it as ABER, right? So that is the annual blood examination rate, right? And we shall be calculating the ABER with the help of this formula, that number of slides made from the fever cases, by total population multiplier over here would be the 100 this time, right? Multiplied by 100, that will be the rate, right? This is the best indicator guys, I am just mentioning over here that ABER, it is the best indicator of operational efficiency of malaria control program, right? Operational efficiency of malaria control program, MCP, that is the malaria control program, right? So for the incidence and impact of the malaria control program, that is best, that was the annual parasite incidence rate, and annual blood examination rate is the best for the operational efficiency of the malaria control program. Please do remember about these two programs over here, right? We're having several other programs, like we shall be having the ASR also. ASR means the annual spleen rate, right? And it is the rough indicator of incidence of malaria, right? It is a rough indicator of incidence of malaria. Right? So these are some of the indicators which we shall remember over here, right? Now let's talk about in itself that what is the malaria control strategy. Let's talk about the malaria control strategy, right? That what would be the malaria control strategy, right? So here we are trying to do the earlier diagnosis. The more early the diagnosis would be, the more earlier we will be able to start the treatment as well, right? So early diagnosis and early treatment, that will be the early diagnosis and prompt treatment. That is the ideology which we are using over here. Earlier diagnosis and prompt treatment. How you will be making the diagnosis over here? How we shall make the diagnosis over here? So early diagnosis, if we talk about, guys, that shall be done by these methods, which I am telling you right now, right? So it shall be done by the RDT kit. What is the RDT kit? This is the rapid diagnostic kit. RDT kit is the rapid diagnostic kit. Please do remember that RDT is the rapid diagnostic kit, right? Other method which we shall use over here, that will be the slide method. SLIDE, that will be the slide method, right? I'll be talking about this picture, but for now let me talk about this one. So RDT, if we talk about, guys, here we shall be having two further methods in the RDT, right? We shall be talking about the histidine rich protein method, right, in the RDT, and we shall be talking about the optimal kit. Optimal kit, right? Optimal kit. So if we talk about the RDT, right, histidine rich protein and the optimal kit. Histidine rich protein is talking about the Plasmodium falciparum. It is able to detect the Plasmodium falciparum, right? As far as optimal kit is concerned, it is able to detect the falciparum also and the vivax also. So Plasmodium falciparum plus vivax. It is able to detect Plasmodium falciparum plus vivax, right? If we talk about the slide method, guys, slide method further shall be classified into two things again. One could be the thin blood film, and other one could be the thick blood film, right? Other one could be the thick blood film, right? If we talk about the thick blood film, it is able to tell us about the species of the Plasmodium. It is able to tell us about the species of Plasmodium, right? It is able to tell us about the species of Plasmodium, right? And if we talk about a thin blood film, it will only be able to tell us that whether the Plasmodium is present or not. So it is only telling us about the presence of Plasmodium. And if we talk about a thick blood film, it is telling us about the species of Plasmodium as well, right? So detect only presence of Plasmodium, right? Detect only presence of Plasmodium, right? So that is about the diagnosis. How you made the diagnosis. RDT kit and the slide method. In the slide method, we are talking about thin blood film and the thick blood film. In the RDT, we are talking about the histidine rich protein and the optimal kit, right? So that's all which you need to remember about the diagnosis part, right? And if we talk about the treatment part, one more thing, guys. If you talk about the slide, right? If you talk about a slide method, who will be preparing the slide as a PSM? As a PSM question, I'm asking you that who will be preparing the slide. So it will be prepared by the MPW, that is the male worker, multi-purpose worker male. So that will be prepared by the multi-purpose worker male, right? So please do remember that as well. If you talk about the treatment, guys, here is the treatment guideline for us, right, which we are following basically. So what about the treatment? What about the management? Right. So management part is given in front of you over here. On the first day, so we are having the first day, second day, and the third day. 3 days are there for us, right? 3 days are there for us. If we talk about the Plasmodium, let me tell you about the Plasmodium vivax first, and then we shall be talking about the Plasmodium falciparum treatment as well, right? So let's talk about. I will be talking about this table, but for now, first of all, let me talk about what we will be doing for the Plasmodium vivax. Let's say there is a Plasmodium vivax, okay, in some patient. So for the Plasmodium vivax, guys, on the very first place, we shall be using the tablet. Either we shall be using the tablet chloroquine, right? That shall be given 25 mg per kg, right, for 3 days. Over 3 days, we shall be giving that, right? And basically, if we are giving, so we shall be giving it as like this. So we shall be giving it as day 1, right? Day 1, then day 2, and then day 3, right? So do remember that day 1, day 2, day 3, we are providing it. But over here, the thing is how we are giving it. Firstly, we are giving the 10 mg per kg. Then again, we are giving 10 mg per kg. And at day 3, we are reducing it, that is 5 mg per kg. right? If we talk about the second tablet, that will be the tablet Primaquine, and Primaquine we are giving it 0.25 mg per kg for 14 days, 0.25 mg per kg for 2 weeks, right? And here it should not be given, please do remember, it should not be given, it will be contraindicated in pregnancy or pregnant ladies, it will be contraindicated in the infant, and it will be contraindicated in the G6PD deficiency anemia. Okay, so these are the MCQs, guys. It will be contraindicated in the infants, pregnancy, and G6PD deficiency anemia. What is that? That is a Primaquine. So chloroquine, Primaquine, chloroquine should be given 25 mg per kg over 3 days. Day 1 10 mg per kg, day 2 10 mg per kg, day 3 5 mg per kg. If you talk about the tablet Primaquine, then it shall be given 0.25 mg per kg, right? That is for 2 weeks. That is for 2 weeks, and it should not be given to the pregnant ladies, infant, and G6PD deficiency anemia, right? If you talk about the falciparum, right? If you talk about the falciparum anemia, that I mean not the anemia. If you talk about the falciparum malaria, that is the Plasmodium falciparum. For that purpose, we are using the regime, right? For that purpose, we shall be using the 2 regimes over here, right? So I am now talking about the Plasmodium falciparum. Plasmodium vivax we have talked about. Plasmodium falciparum is most commonly found. Plasmodium falciparum is most commonly found, and here also, the examiner might play the trick. What they shall be asking you, usually Plasmodium falciparum, they shall be found in the northeastern state, that is the endemic for the Plasmodium falciparum, right? Northeastern states, and one is that all India. One is for all India, right? So there could be two scenarios. So for them, how to deal with that? For the northeastern, what we are using, for the all India, what we are using, what regime we are using, they are a bit different over here. Let's talk about that. For the northeastern part, guys, we are using the RT meter. Right? We are using the Primaquine, right? And we are using the Lumefantrine, right? These 3 drugs you should remember for the northeastern states, because it is endemic. Plasmodium falciparum is endemic in those states usually. For all over India, we are having bit different regime only. We are using the artesunate tablet. Yes, we are using the artesunate. Please add the tablet over here as well. Okay, tablet. Right, these are not the injection, we are using the tablet only. Tablet artesunate, yes, we are giving that. Okay, and tablet Primaquine, are we giving it? Yes, tablet Primaquine is also given. And the tablet here, Lumefantrine, we are not adding. Here we are using the sulfadoxine. With that, we are also using the pyrimethamine. How we are using it? Let's go to this table now. Right? What you can see, guys, here you can see the different blisters are there. I mean the pink color, yellow color, green color, red color, and all of these things, right? And the white color at last. So how we can understand this table? Very, very easy, guys. Please be with me over here. Okay. Otherwise, you will be finding the difficulty in understanding this table. First of all, AS is for artesunate. AS means artesunate. Okay. First problem solved. What is SP? SP is S for sulfadoxine and P for pyrimethamine. S for sulfadoxine and P for pyrimethamine. Okay, next problem solved. So AS is for artesunate. AS if they are writing, they means artesunate. AS if they are writing, they means artesunate. AS if they are writing, they mean artesunate. Right? AS means artesunate. Tablet artesunate, right? Tablet artesunate can be given for the northeastern state also and for the all India purpose also. They are giving in both. What about SP? SP I told you sulfadoxine pyrimethamine. SP means sulfadoxine pyrimethamine. What about PQ? PQ is the Primaquine. So PQ I am writing over here. PQ will be the Primaquine. Very simple. Now it will be simple. I guess now it will be simple to understand. At the first day, in the first day what we are using, second day what we are using, third day what we are using. Let's talk about that. Guys, if you talk about the first day, right, we are giving what? How many drugs? 3 drugs. First day, how many drugs we are giving? 3 drugs we are giving. AS is for artesunate, S is for sulfadoxine, and P is for pyrimethamine. So artesunate, sulfadoxine, pyrimethamine, right? They will be given in the first day, right? So age groups are different. Age groups might be different. For example, For the 0 to 1 year of age group, we are giving the pink blister, right? Now for the 1 to 4 years, we are giving the yellow blister. Then 5 to 8, we are giving the green blister. 9 to 14 years, we are giving the red blister. And above 15, we are giving the white blister, right? So how many tablets they should be taking over here, right? For the pink blister, we are taking the 1 tablet, right? We are using the 1 tablet, that is for 25 mg. And then you shall be increasing it, right? So for the, as the age is increasing, we will be increasing the dose also. So 25 mg, 25, you will be keep on adding 25 mg, then 50, then 100, then 150, right? And then 200. Okay, you shall remember like that, right? 25, 50, then 50, 50, you need to add 100, 150 and 200, right? Simple. If you talk about the sulfadoxine and pyrimethamine, right? Here we are using the sulfadoxine 250 mg and pyrimethamine 12.5 mg, and that's how it will be keep on increasing as the age will be increasing, right? Artesunate and the primaquine will be given in second day. So in the first day 3 tablets, second day 2 tablets. In the first day artesunate, sulfadoxine, pyrimethamine. In the second day artesunate and the primaquine only. And the third day only and only tablet artesunate, right? Only and only tablet artesunate, right? So that's how you shall understand that how this table is there, right? I don't think they will be asking you that what dose they will be giving over here, but at least you should be understanding that which tablet should be given on day 1, which should be given on day 2, how many tablets we are giving on day 1, how many tablets we are giving on day 2 and day 3 and all like that. And we should be understanding that how we are using the Plasmodium falciparum and the Plasmodium falciparum northeastern state, what drugs we are giving, and in the all India state, what drugs we are giving, right? Okay, so day 1, day 2, day 3, you understood what we are giving, right? So again guys, day 1 what we were using, and day 2 what we were using, and day 3 what we were using. Again, yes, it is the revision guys. So day 1 we were using the tablet artesunate, tablet SP sulfadoxine, and we were using the pyrimethamine. Yes. On the day 2 what you were giving? You were giving the artesunate again, but with that we are adding the primaquine over here, right? I am talking about the all India regime over here. And day 3 if you are talking about, then only and only tablet artesunate will be given. Okay, so please do remember this regime, very very important. Day 1, day 2, day 3. Day 1 3 drugs are given, day 2 2 drugs are given, and day 1 only 1 drug will be given, that will be artesunate. Okay, right. Once you understood that guys, now we shall be talking about, okay, one more thing guys. If you talk about the artesunate, it will be contraindicated in the first trimester of pregnancy. Artesunate is contraindicated in the first trimester of pregnancy, or in the first 12 weeks of pregnancy, first trimester of pregnancy. Please do remember that it has been asked twice. So please do remember that it has been contraindicated. Which drug? Artesunate is contraindicated in the first trimester of pregnancy, right? Okay guys. Now once we talked about that, okay, now we shall be talking about the malaria elimination program. I will be coming to the insecticide toxicity level and all. I will be coming to that. But for now, let me talk about the malaria control program, or the malaria elimination program rather, malaria elimination program. Okay, so what points we shall be talking about if we are talking about the, so what points we need to understand about the malaria elimination program guys? It is between the 2016 to 2030 because it is coming under the SDG program, and that is working sustainable development goals, right? They are till 2030, right? Okay, so on one side, we shall be talking about the phases. And the criteria as far as malaria elimination program is concerned. So what are the phases and what are the criteria? Very simple to understand. Please look over here, right? First phase is the prevention of re-establishment. That re-establishment of the malaria should not be there in any region. So prevention of re-establishment, right? And we are talking about which areas? If we are talking about prevention of re-establishment, we are talking about those areas where zero endemic rates are there, zero endemic malaria cases are there. So we don't want that this area will be having the malaria cases again. We don't want that, right? So usually we are saying that states with the zero endemic malaria cases, In that cases, we are talking about the prevention of re-establishment over there as far as phase is concerned, right? Second phase which we shall talk about over here, that is the elimination phase. That is the elimination phase, right? Third phase which we shall talk about over here, that is the pre-elimination phase. Pre-elimination phase, right? And the fourth one which we shall talk about over here, that is the intensive control phase. Intensive control phase, right? If we talk about the elimination phase, guys, in the elimination phase we shall be talking about the states where the annual incidence, we have talked about the API. So states with API over here, it will be lesser than 1 by 1000, right? Pre-elimination phase, if we talk about the states with API, that will be lesser than 1 per 1000, but in some district they have the API more than 1 per 1000. Okay, fine. Intensive one, the states with API more than 1 per 1000, and usually they are the 10 states. Usually they are the 10 states, right? Okay, guys. Once we have talked about that, we shall be talking about the insecticides spray now, right? We shall talk about this insecticide spray, how we shall be controlling the malaria, right, by the help of the insecticides and residual spray and all of those things, right? So let's talk about that as well. So firstly, we shall be talking about the indoor residual spray. We shall be talking about the indoor residual spray. Okay, indoor residual spray. Okay, indoor residual spray or insecticide pesticide. Okay, we shall be using insecticide treated net, basically, not the pesticide over here. So we are having a mosquito nets, right? Because what we are happening, if we are talking about the malaria, we are talking about the mosquito, right? And usually we are talking about the Anopheles mosquito, right? Mainly the female one. So over here we shall be actually getting the prevention by the help of mosquito net, and usually these nets are the insecticide protected net, right? Insecticide treated net. So indoor residual spray, here we shall be talking about the net. These will be the insecticide treated net. Insecticide treated nets. I mean the insecticide treated mosquito nets, right? Now the thing is that if the API, right, is more than or equal to 2 per 1000, right, then in that case you will be using the indoor residual spray. You will be using the indoor residual spray. IRS is the indoor residual spray. IRS will be the indoor residual spray, right? And I will be using the term ITN for the insecticide treated net. So IRS will be giving, or in that case, if the annual, right, what was the API, right? I told you the API, right? And it was an indicator of something, right, in the malaria control program. So API, if you talk about, guys, API, if it is more than 5 per 1000, then we are giving the IRS, that is the IRS, right, that is your indoor residual spray, and we are giving the insecticide treated net as well. So in that case we should be using both of these things, right? So let's talk about the IRS first. Right, that will be the indoor residual spray. IRS, that will be the indoor residual spray, right? So in the indoor residual spray, guys, we are talking about the nerve poison. Nerve poison, it is also called as the contact poison, right? Nerve poison or contact poison, right? In the nerve poison or contact poison, we shall be using several methods, right? For an example, we shall be talking about the natural method, right? In the natural one, we are talking about the pyrethrum. Right? Then we shall be talking about the artificial method, right? In the artificial one, we are using some. For an example, we are using the DDT. We shall be using the malathion. This is the least toxic, right? Then we shall be using the BHC. We shall be using the lindane, and we shall be using the gamoxine. Right? So these are some of the insecticide we shall be using, or I would say the nerve poison we should be using over here, right? Then we are having the second category, right? That first was the nerve poison or contact poison. Second category is the stomach poison. Where they are using the Paris green, right? Where the Paris green we might be using, right? So third one which we shall use over here, that is the space spray, right? That is the space spray. where we might be using the pyrethrum. We might be using the pyrethrum, right? So P-Y-R-E-T-H-R-U-M, right? That's the pyrethrum. Okay. That is about the indoor residual spray. That is about the indoor residual spray, that is the IRS. Now, what about the insecticide treated net? So let's talk about that as well. IT, and if the API is more than or equal to 5 per thousand, then in those cases we shall be using the both IRS plus the IT, and that is the IRS is the indoor residual spray where we are using the stomach poison, we are using the nerve poison, that is the contact poison, or we shall be using the space spray. And here I am talking about the insecticide treated net, right? For that purpose, please look at this image over here, insecticide toxicity levels, right? So now let's talk about the insecticide toxicity level, guys, right? Before talking about the insecticide, I mean the insecticide treated net. So insecticide toxicity levels, guys, look over here. What you need to remember, just look at that. The red one, you can see the red label. The red label is extremely toxic, guys. Please remember that, very important. Then you are having a yellow one. Yellow means highly toxic. Red label means extremely toxic. Yellow means highly toxic. Blue means moderately toxic, and the green means slightly toxic. So please do remember this table, right? And which I have highlighted only that you need to know over here, and the labels also you need to identify, right? So the red one is the extremely toxic, yellow is the highly toxic, blue is the moderately toxic, and the green one is the slightly toxic over here, slightly toxic label, right? Okay, these are the insecticide toxicity levels. Now let's talk about the insecticide treated nets. ITN is the insecticides treated net, right? So now let's talk about the ITN, that is the insecticide treated net, right? Insecticide treated net, if we talk about, basically they are treated with, the nets are treated with one insecticide over here, and that is the deltamethrin, right? The insecticide which we are using over here, that is the deltamethrin, right? Now we shall be having the two types over here, guys. We shall be having the two types of the ITN, right? So one type over here, okay. So let's talk about the types of the insecticide treated net, right? One type is the NITN, that is the normal, that is the normal insecticide treated net, and another one is the long lasting insecticide treated net, right? So N is the normal, right, and long lasting is the LL is the long lasting, LL is the long lasting ITN, right? So normal one, it will be needing the retreatment after 6 months, right? It needs the retreatment, right? It needs to be retreated after 6 months, okay, and it needs the retreatment after 3 years. So it is having a long life. That's why we are talking about the long lasting, right? So long lasting ones we are using, and treatment we are doing with what? We are doing the treatment with the deltamethrin, right? So normal one, they will be using the retreatment. They will be needing the retreatment over here after 6 months, and long lasting one, they will be needing the retreatment after 3 years, right? So that much long time over here. Some important salient features over here, which has already been asked in the exam. So I'm just telling you over here, maximum diameter of hole which should be there of the mosquito net for the prevention of the entry of the mosquito into the net over here, that should be the 0.0475 inch, right? The maximum holes per square inch, maximum hole per square inch should be around 150, right? And if I have already talked about in the in the entomology that Aedes flight range, that is the 100 meter, and it should be capped the no breeding zone of the Aedes outside the hospital in the range of around 400 meters. I have already talked about that in the entomology chapter where I was talking about the Aedes, right? Okay, please go through that for that particular detail, right? So now we shall be talking about some other components, right? So we shall be talking about some of the larvicidal drug, right? So that we shall be stopping the larva to grow of the mosquito, right? So now we shall be talking about some of the drugs which are larvicidal drugs, right? They shall be killing the larva over here, right? So for the larvicidal drugs, guys, here we shall be using the drug or we shall be using the fish. We shall be using the drug and we shall be using the fish. Yes. So in the drug, if you talk about, guys, we shall be using the Tamifos or we shall be using the abate, right? That is kind of a poison for them. And for fish, we shall be using the Gambusia and the guppy fish. Gambusia and the guppy fish shall be used for the larvicidal drugs, right? Okay, most common site of the Aedes breeding, that is the overhead tank, right? So basically, Aedes mosquito, if you talk about, they are actually, breeding themselves in the clean water, and usually in the overhead tank, right? That water is the perfect for them, right? Or the rainy water which has been deposited somewhere over there, that could be the breeding site over here, right? That has been asked once, so that's why I'm just mentioning about that, right? So here, guys, we have talked about in this chapter about the NVB DCPs carrying 6 diseases over here. Among them, we have talked about the malaria over here, right? In the upcoming sections, we shall be talking about the other diseases which are covered over here. For example, Filariasis, about the Japanese Encephalitis, about the Dengue, Chikungunya, kala-azar, and all of these things, right? Okay, so with that, I would like to thank you for seeing this one till here, and thank you so much. I'll be seeing you in the next one. Bye bye.